Welcome to Healthcare Triage Live. It's always such a surprise when everything goes up. Thank you for joining us. I was just taking a pause, engaging my mood, and actually nothing truly irked me right before coming on, although I was in a Twitter argument with somebody about, oh God, this guy's still going, about whether Obamacare is in a death spiral and the definition of death spiral. Who cares? Anyway, why do I allow myself to get into these arguments? I should know better than to ever engage. I know. Anyway, thank you for joining us. We're always happy to be here. Hope you've watched our recent episodes on Healthcare Triage. We've had a lot of good stuff. We've got a lot of good policy stuff going into a new administration on Friday. President Trump. It's going to happen this Friday. Anyway, yeah, there we go. Okay, so check out our merch, actmerch.com. The lunchbox is so awesome. I'm watching my wife and my daughter use them, and a couple people have tweeted how they got them, and it makes me so very happy to see you guys having that stuff and be happy with it. If you can, support us, patreon.com/healthcaretriage. We always appreciate your support. We're always overwhelmed by it. It's what keeps the lights on, literally. I'm surrounded by lights, and you help to keep them on. And to keep us doing stuff like this, which we really do appreciate, because, you know, everybody here needs a job. Helps to pay the bills. Okay, let's get right in with things. First question goes to Nivedan Kaushal. What's the process of creating a healthcare triage episode? How do you gather research and transform it into a script, make visuals, film it, etc.? Thanks. You know, I'm going to answer you quickly, but this is a good time to pitch NerdCon Nerdfighteria in February, the 24th, 5th? I'm looking at you guys. It's Saturday. They're going to look up the date. It's in Boston. You should come. I'm going to be on a number of panels, but one of them is going to be like a Healthcare Triage Live panel there. This is the perfect time because you will have 25th and 26th, February 25th and 26th at Boston at the Convention Center? At the Convention Center. We'll all be there, all of Healthcare Triage, and you will have all of us in the room on a special panel just to talk about Healthcare Triage, and you could ask these kinds of questions, and we could, each of us, talk about the process of what we do. So, what do? I come up with an idea for a script. Sometimes I'm adapting it from something else I've already written. Sometimes I'm running it de novo. Oftentimes it has to do with the study I saw. I read the study, I do something, I do all the research that I need to do, and then I write a script. And when I write a script, it's very much like I write like I would speak, which has become my writing style in general. So you'd be surprised if you read a New York Times column, if you watch enough videos, you can hear me speak probably while you do it. Then I send it to Stan and Mark and Meredith sometimes for editing. They take a look at it and they make any changes they should. I try to break it down into bites. Then Stan loads it up when I arrive. If you could see, there's a whole process to setting up the room. And we're in a studio right now. We're like literally right over there is Mental Floss, and right over there is Crash Course Computer Science. That's what they're filming right now. There's a wall here, which is a huge map that you can't see, which is like Crash Course Human Geography. And there are pillars, which were from Crash Course Civics. And so like there's a globe, which I think was from all of Crash Course. Regardless, there's a studio, there's all kinds of stuff. This is Healthcare Triage, so we got to set it up. Lights go up, mic goes on. This computer's usually not here. We have a whole teleprompter set up. Stan loads it in. Mark sets up all this stuff with audio and everything else. We tape it, which is, I like to think, pretty streamlined. I don't take too many takes, and with the teleprompter, we zip through it pretty quickly. And then Stan goes to work, and this is where I'm going to now be making it up, so Stan can correct me later at NerdCon Nerdfighteria if I'm lying, but takes all of the big massive video file and then breaks it down into clips. And we now have we have like a high-res camera actually, so I used to have to move physically to do the jump cuts, but now I just sit still and they can actually just shift the framing of the camera to make it look like I'm moving and doing the jump cuts. Mark makes all the graphics. They make a rough cut, which we all review to make sure it looks good and there's no mistakes. Sometimes a few more things need edited. Bam! And then it gets uploaded into Healthcare Triage. We usually tape a couple episodes at a time. We do news every week. But usually we film 2 episodes and a news today. We'll probably film 2 episodes and a news tomorrow. Sometimes I'm out of town. We have to film things in advance. There you go. That's how it gets done. End kicker. What are high-risk insurance pools and do they work? So, no one wants to insure very sick people. It's a bad bet. It's economics. No moral judgment there. There's a reason that the government winds up covering the elderly and the poor. They're both a bad bet. The elderly cost a fortune. No one wants to cover them. Poor people, often very poor to begin with, but they're also in general more unhealthy. No one wants to cover them. Sick people tend to be poor. No one wants to cover them. So the idea is that instead of like asking the private insurance network or insurance system to take in these very sick people who would raise everyone's rates and make everybody unhappy, they would instead take the very sick people and put them over there where the government will cover them in a pool over there, and then everybody else is left generally healthier and the market works a little more better. The problem is that there's no magic to that high-risk pool. They cost the same to cover whether they're here or there, and so high-risk pools are incredibly expensive and the government almost never funds them adequately. So the insurance winds up still being incredibly expensive for sick people, which means it gets its own kind of sort of death spiralish thing where only the sickest of the sick want to buy the insurance or get the coverage, which means it costs even more per person. So it never works right. They're inadequately funded because there's no magic, again, is what I said. People treat high-risk pools as like, oh, I can put them over there and then we can cover them. They're still ridiculous in terms of expense. And so high-risk pools could function if we were adequately funding them. And there's always the trade-off. It's like, do you want there to be better access for those people? It's going to cost a lot of money. We don't want to spend the money. There's not as good access. That's the trade-off. So there's nothing inherently wrong with it. Medicare technically is a high-risk pool. We just adequately fund it. We say, I don't care if it costs $1 gazillion a year, we're going to fund it. No one does that with high-risk pools statewide. So they never really seem to work. Lisa Jones, any thoughts on the recent study that basically said we are in better hands with female rather than male doctors? Did the media report the study well? All right. I saw that study. I respect the people who wrote it. I think that their methods are fine. Here's my problem with it. It is epidemiologic. It's an association. I'm not sure how big it is. There are many other factors that might be unmeasured with it that could still do this. It was basically saying it had to do with one specific instance of one thing quality where it was better than female rather than male. My biggest problem, however, is one study. And until we see other studies which show the same thing, it falls prey to the same risks that many studies like that do. We see an association. Is it real? Is it not? We don't quite know yet. We need to do it. Plus, if they had done the study and found the opposite, that males were better than females, that's when I always wonder, would they still have tried to publish it? Would it have been accepted for publication? There's a publication bias there. Would it have been promoted by the media in the same way? And I don't know. I saw a lot of articles on it. In fact, I saw a lot of people saying like, didn't you see the article? Why aren't you doing it? And I'm like, well, for this reason. I try to update my priors. I have no trouble. You know, there have been many studies showing that women are not as well paid in medicine. We cover that. There have been many studies showing on disparities in health. We will cover that. This one was one where I was like, I just don't know if it was enough of a bit of evidence for me to go crazy and start talking about it and everything else. It's one example, and I don't know that if it was replicated in other studies, especially in a prospective study, then I would feel much more comfortable talking about its validity. Another question, are home remedies for heartburn, such as apple cider vinegar and baking soda, effective beyond placebo effect? Well, those are not placebo. So apple cider vinegar, I'm not sure, but baking soda, you're basically taking a base. And when you have too much acid in your stomach, that's what often causes the heartburn. If you take a base, and by base I'm talking about acids and bases, the pH, it will lower the acidity of your stomach and that will drive down your heartburn. There's no question that works. Milk works for that reason. Basic baking soda works that you're basically treating the acidity of your stomach. Now, I don't know, apple cider vinegar, I would think in my head is probably acidic, so I don't know that one necessarily works. But baking soda is all about it being a base. And so if you reduce the acidity of your stomach, that will help your heartburn. H2 blockers stop the acid release. That's what the medication does. Proton pump inhibitors also do sort of the same thing. I mean, they're all about lowering the acidity of your stomach contents. When you take Tums, you're also doing that. I mean, basically that's what you're doing. You're basically treating the local contents. So if you eat things which are basic, yes, they will help. No, they may be less of a therapy than some medications are, but they're not placebo effect. They actually do lower the pH of your stomach. And kicker, how effective are health savings accounts? Excellent question, difficult to answer. Here's the thing. There's nothing inherently wrong with the idea of trying to say like, well, there are options for people who want to get catastrophic care and we will give them a high deductible healthcare plan and we'll pair it with a health savings account. The health savings account is often sold as like, well, it's such a great idea for everyone. It's the way to solve everyone's healthcare problems because then people are saving their own money. That money grows, tax-free. It's wonderful for everyone. Of course, it ignores the fact that we're talking about federal income tax and a good portion of the country pays very little, if any, income tax. If you pay no income tax, and you're among the 47 or some percent of people who don't, then a tax deduction is of no value to you whatsoever. None. So who are health savings accounts great for? People in high tax brackets. I'm a physician. I do fine. So it's like I'm in a reasonably high tax bracket. So a health savings account is great for me theoretically, in the sense that I don't have to pay taxes on the money in it. Well, if I'm in a high tax bracket, that tax deduction is enormously valuable to me. It's why all tax deductions are much more valuable to people at the high end of the socioeconomic spectrum than people at the low end. So it's better for me. Having said that, you're only paying taxes on the money you're making. It's harder to make money in health savings accounts these days than it used to be because interest is so low. So even that's not of great value these days. So the incentive to use the health savings accounts because you're going to make money on it and you don't have to pay taxes on it doesn't apply to the people who need it the most. The people in the lower half of the socioeconomic spectrum. So health savings accounts are fine for me. I don't think they're fine for everybody. I don't think that they're nearly the incentive and the wonderful opportunity for everyone that they are for people at the highest end of the socioeconomic spectrum. John Espinoza, are allergy reactions worse with each exposure? For some, that's why like people sometimes get anaphylaxis not the first time they're exposed to something, but the second. It has to do with a delayed response and how your immune system works and building up certain types of antibodies. But that doesn't necessarily hold true for all allergies. Like I don't think that seasonal allergies necessarily apply in that way. And kids will sometimes outgrow allergies, but some severe allergic reactions do get worse on subsequent exposures. But I bet that there's a plateau and then a level. So the answer is sometimes. Trey Harris. Would you agree with those of us with chronic expensive conditions would you agree that those of us with chronic expensive conditions break the insurance model for healthcare and that's why high risk pools keep coming up? Sort of. All insurance is based, this is what you have to do, all insurance is based on the idea that we all put in money and the people that need it the most get it. That's how insurance works. When I buy fire insurance, I know that the person whose house burns down is going to get the money. When I buy car insurance, I know that the people that get an accident are going to get the money. When I buy health insurance, I know that the people who are sick are going to get the money. The problem is that a chronic condition means that before we even start, we know you're going to cost a lot of money. If my house is already on fire, no one would give me fire insurance. If I'm in an accident, no one gives you car insurance. Chronic conditions break the idea of how insurance works, period. Of course, if that's the question you're asking, yes. High risk pools keep coming up because no one wants those expensive people in the pool because they can make everyone's insurance more expensive. Of course, that's true of old people, which is why, again, Medicare is a high risk pool. Just own that. There's nothing inherently wrong with it as long as you fund it well. Now, on a per person basis, Medicare would cost much less if we kept adding in younger and younger people, because that would make the health pool less sick. High risk pools are very expensive. The more and more healthy people we let in, the lower the per person rate is. But of course, it raises the per person rate on everybody at the low end. So high risk pools are a way to try to make the insurance system work great for healthy people. That's fine if that's how you want your healthcare system to work. A lot of people think that the healthcare system should work for the sick people, and continuing to break them off and put them in a separate place doesn't necessarily do that. It just changes who's paying for the expense. If only healthy people are covered by private insurance and only sick people are covered by public insurance, then public insurance is going to cost a fortune and private insurance will be very cheap. That's sort of what we have now, is we've already carved off again the soldiers, the elderly, the disabled, the poor, pregnant women. I mean, we keep carving them off and putting them on the government, and then we complain that the government costs too much. High-risk pools are no magic. It's the same kind of thing. Dominic T, public option, pros and cons. All right, public option pros. Theoretically, it would increase competition. Theoretically, it would, the more insurers you add to every market, usually the cheaper the plans cost overall, and also the slower that the rate goes up overall. The pros are that it provides theoretically a chance for insurance to be sold without a lot of the bells and whistles. They come with private insurance plans like advertisement, like executive salaries, like shareholders and dividends, if that kind of stuff exists, like more underwriting, marketing. I mean, there's tons of stuff that goes into insurance that's not necessarily insurance, even though that's been limited to some extent by the ACA to like 15% or less by some plans. But regardless, that's the idea. The cons. The biggest expense of setting up an insurance plan, and if you ask a private insurer, most will tell you this, is setting up the network. Making the deals with hospitals and providers to get a network, and then trying to funnel your beneficiaries to be in network or out of network, that's a lot of what it costs to start up and get a plan going. It's why the whole selling across state lines won't work. Because my plan, which is very nice in Indiana, has a network of Indiana doctors. And someone in Texas would never want to buy my plan because it covers Indiana doctors and network. It doesn't have Texas doctors. If they want a Texas plan, they have to go to a local place and made a deal with theirs. That's how you save the money. And the Indiana companies might not have set up a network in Texas. That's why they're not selling a Texas plan. If they do set up a network with Texas doctors, they would sell the plan in Texas, which is what some things like Blue Cross and Blue Shield and Anthem and a lot of the big players already do. What we want when we talk about selling across state lines is we go, oh, well, there's a cheap plan in Indiana. I want that plan, and I want it to work in Texas. They won't. It's cheap for because it has like Indiana, and it's cheaper to give care in Indiana perhaps than it is in Massachusetts. And that's why it's not magic. So anyway, the public option, the problem with that is that the public option would have a very difficult time. It might even be illegal for it to set up networks. Medicare, for instance, has no network because Medicare has to Medicare has to set up and say we have to do things nationwide. Clearly we can't have a network. So what Medicare does is have regulations and laws which say, hey, if you either accept Medicare nationwide or you don't, it's a huge amount of people, so most doctors wind up doing it, and you take these low rates and we're tapping out. Well, they could do the same thing at a state level. Medicaid can't do the same thing because doctors don't need to see Medicaid patients like they do Medicare patients, because Medicare is a crap ton of patients spending a lot of money, and Medicaid, well, their reimbursement rates are even lower, and a lot of doctors I can get by without having to see the very poor. I'm not gonna. And so they don't have networks, but there is a smaller number of doctors that accept the insurance. So public option go one of two ways. It can try to set up those networks, but I don't even know if that's legal because neither Medicare nor Medicaid actually can say, well, we're going to pay this doctor differently than we pay that doctor and this when they work in the same place, because they just don't do that. It would almost be it feels almost like it would be graft or ethically challenged. On the other hand, what they could do is say, Medicaid or Medicare, we're just going to pay less, but then a lot of doctors are going to say, well, we don't want to cover those people. And so the public option may just reimburse less than everyone else. That's how they save money. And if they do that, lots of doctors may not take it, in which case people won't want the public option, and then it'll fail. So it will be difficult. It sounds good. It really does. But the only ways that I can think of to make it work are to basically just say, we're going to reimburse doctors less, and then hope that lots of doctors still want to take those patients. I don't know how well that'll work. I don't know how popular that will make it. Medicaid, while being popular for its being free, is not popular sometimes in terms of its who you can see type of doctors and how wide is the network. So there will be trade-offs as always. If you want cheaper, it probably will come out of access. If you want greater access, it's probably going to cost more money. That's the trade-offs of the Iron Triangle. We talk about this all the time. Corey Handworker, are there any studies on the safety or efficacy of the potato hack, the diet where you eat nothing but potatoes for a month, popularized recently by Penn Gillete? I'm going to guess that the potato hack is just you get so tired of eating potatoes that you don't eat much. There's nothing magic about potatoes. As long as anything is short term, you're probably going to be okay, especially if you start out overweight or obese where you're not going to be malnourished. I mean, I'm sure Penn Gillete was not malnourished before he did this. I've listened to him talk about his diet afterwards, and his diet is very much he just restricts, if you restrict certain foods, you usually wind up eating healthy. He also was, eschewing processed foods. He may be even eschewing meat, I can't remember. And he doesn't even call them cheat days, if I remember correctly. It's just normal days where he lets everything go. Great. It's a diet that works for him. I don't recommend any diet on this channel. In fact, we have a whole episode on food recommendations. We have a whole poster of my food recommendations, which is on the Facebook page. They're not saying any diet. It gets into sort of general holistic ideas of how you're eating. I bet the potato hack would work under the food recommendations that I have. It's a non-processed food. You know, you're still watching what you eat and drink, and you're still, so yeah, it's fine probably. But you know, I don't also think that we're meant to eat one thing. That's not how biologically we're set up. It's not how evolutionarily we're set up. So it's not the kind of thing I would do, but I try not to judge what other people are doing. It's clearly worked for Penn Gillete. On the other hand, he has massive amount of resources that many other people lack. And I'm sure doctors were involved, and nutritionists and lots of other experts. So I don't know. It's not something that I would promote in my clinic. It's not something I'd promote here. But if it worked for you, I wouldn't get on here and say you did it wrong. I'm happy for you. Michael Moser, what's the actual evidence regarding moderate light drinking, say 1 to 2 drinks per week during pregnancy? Books like Expecting Better say it's okay, but others say absolutely not. Oh, I have a lot of respect for Emily Oster and her book. And I've written a book on the Bad Food Bible. It'll be out in November. There's a whole chapter on alcohol where I actually talk about this too. So without giving away the book too much in advance, Emily's not wrong. She talks about the fact that most of the evidence for drinking and bad outcomes like fetal alcohol syndrome are on binge drinking, which she absolutely says you should not do, and I would agree. And she talks about the fact that the evidence saying that moderate light drinking of 1 to 2 per week is not nearly as robust, is sort of scattershot. It's all over the place. And that even OB-GYNs, when asked, will be like, yeah, the evidence isn't so great. You know, people have actually been lightly drinking for a long time during pregnancy with that. So you shouldn't binge drink. You shouldn't probably do shots. You shouldn't be like, you know, taking too much at any one time. Having said that, the evidence is not nearly as, you know, pejorative against sort of light drinking as people would expect. But that's not how we do things in the United States. We're an all or nothing shop. And so, you know, we say, well, if any drinking is bad, then if massive drinking is bad, then all better. We don't trust the public to do nuance. We say, no drinking, no drinking. And then we even go so far, and we even did an episode on this to be like, hey, if you are ever drinking, you should be on birth control because you could possibly get pregnant. No, there's nuance in life. The evidence against light and moderate drinking is not nearly as robust as the proclamations would have you say. Having said that, there's no counterfactual. So it's very easy to say, never drink. That's the safest thing to do. It's also easier to say, never put your child in a car and they will never die of car accidents. And car accidents are the #1 killer of children. But we never do that because we recognize that that's ridiculous and that people have to get in cars to work in normal society and that the benefits that we get from driving cars outweigh the risk of killing many children a year. We do. For some reason, we can internalize that risk benefit and be okay with it, but when it comes to other things, we can't. And so I think Emily and Expecting Better were pretty well written in research. Doug M., is there a difference between brand name and generic prescription medication? Some people swear yes, some people swear no. Is there a difference? It depends. We did a whole episode, I think, on generics versus, did we not? I think we did. Generics, we did. In fact, I think Rachel helped us out on that one, our intern. So some of it is like the actual like medication part is almost exactly the same. The molecule is the same. What can be sometimes different is what goes along with it. You know, how it's put together. The rest of the, you know, when you take a pill and it says it's got 50 milligrams of medicine in it, that pill is mostly not medicine. And the other stuff that's in it can theoretically change how the drug works. So that's important to consider. Most generic medications you buy off the counter at this point have considered that. So theoretically, there can be a difference if the preparation is different, if the inert compounds are different, if the way it's housed are different. So, you know, even like in stuff that when I give out hydrocortisone cream, there's a huge difference between a 1% cream, a 1% ointment. Because an ointment is super thick and that actually makes it much more potent. But that has nothing to do with the 1% of the stuff being hydrocortisone. It has everything to do with the other stuff in it. So preparation can matter, but for most generic prescription medications, they are biologically the same. And so for most, it really doesn't make that much of a difference. And again, I encourage you to go watch that episode. We go into the research and all the other stuff in much more detail there. Dominic T, how does one get involved in health research? Like what I do. Okay, so my route was college, medical school, residency, fellowship, where I also got a master's degree, and then a job as a researcher. But that took me till I was in the 25th grade when I graduated. That's not for everybody. Other people go the straight college, master's or PhD route, they're a scientist. Other people, so you don't have to have an MD to be a health researcher. Most health services researchers are probably PhDs. Lots of scientists are PhDs, even in health research. The NIH has periodically tried to promote or get rid of, we call ourselves clinician scientists, but not all are. There are nurse scientists, there are doctor scientists, there are PhD scientists, there are all kinds. I know dentists who are scientists. I know doctors in, rehab who are, scientists. So it usually involves getting, you can do it with a master's, but if you want to do like independent investigator research, you really need a terminal degree that's a doctorate in some way. But there's lots of routes. Mine, it's funny because I often talk when people meet with me or when I advise mentees and they ask me, well, how do you get to where you are? Mine feels like an incredibly circuitous pathway, but when you look in the rearview mirror, everything looks straight. I didn't know I wanted to do this. Thought I was going to be a doctor, probably because my parents convinced me of that. And I question that now all the time. And then I thought, well, I wanted to be a pediatrician. And then I thought maybe I'd do research. And then I thought maybe I didn't get into like this until way late in the game, way late. And I didn't get into healthcare triage, I was like 3 years old. Doing this kind of stuff, super recent. I'm 44. I didn't do healthcare triage until I was after 40. I didn't write for the New York Times until I was after 40. I didn't start blogging until I was in my mid to late 30s. It's like a lot of this is very late in the game. So I didn't have a path. I didn't have a plan. I wound up here. So I don't know that my route's the best. But having said that, this is how I got here. And so people ask me, would you do it all again? And I'm like, I'd have to, because this is the route that I know to get here. So the usual advice that I give people when they come and ask me questions like this is find the people who have the job you want and ask them how they got there. You can sometimes do it faster. You can sometimes do it better. You should talk to multiple people. You should get lots of advice and pathways. But mostly, if you want to get involved in health research, you're going to need research training, you're going to need health training. There's lots of ways to get that done. Diarmuid Coughlin, what's your beef with John Ionnandis? My beef, I love John Ionnandis. Oh, I bet you all took my tweet wrong. Jesus, no. I would be thrilled if John Ionnandis was the NIH, like head of the NIH. I can't believe that's an option. Like literally blows my mind that could possibly be. I would be thrilled. I got to be honest, working for John Ionnandis is like one of the few things, when people say to me like, would you take another job? And I'm like, well, I'm very happy my job is like, working in John Ionnandis' NIH would be tempting. Like tempting. Like, no, you took this entirely the wrong way. I pray you're watching right now. I love John Ionnandis. I cite him all the time. He's in our upcoming release NIH-run thing on reproducible research. I think his papers on like why most researchers, come on, all my columns are about like how you shouldn't trust the crappy research. That's what Monday's column in the New York Times was about. Go read it. Like we shouldn't be trusting this research. I think John Ionnandis is awesome. So when I tweeted that, I was like, I can't believe this is possible. Not I have a beef with him. Not at all. And if that's not where you thought I had a beef with Ionnandis, let me know where you got that impression, because no, not true. Abra, are you answering questions right now? I believe the answer to that is yes. Yes, I am. Last question. Jonathan Ekman, with the recent approval to repeal the ACA, what's the expected replacement time? In the interim, what happens to those who are on Obamacare? How will this disrupt the insurance industry? And I'm rubbing my forehead because, oh my God, I don't know. No one knows the answer to this, not the people who are in power and voting on it. So look, they've started a pathway to try to repeal it by reconciliation, but they can only repeal some parts of it by reconciliation. The other parts of it, the major things like the regulations and the guaranteed issue and the community ratings, those cannot be repealed by reconciliation. They don't have the votes. They need to do a replace thing, and replacing can't be done with reconciliation either. And so not only that, there's huge disagreement on reconciliation. I think we have an upcoming video on the replacement plans, or did we do that one already? The many Republican placement plans. It's already up. Go watch it. There's huge areas of disagreement still. So it would take a long time to replace it. And since you have a couple senators who've already vowed not to repeal it without replacing it, I don't even know if they can get the repeal done. They only have 52 Republican votes right now. If they lose 3, it's over. I mean, forget even the reconciliation then. They can't do it with 49 senators. They have to have 52. So I don't think the repealing and the replacing is nearly as set in stone as many people think. I don't think it can happen nearly as fast as people think. They still have it for a replacement building. Now, of course, all bets are off. If they just flat out repeal it, the piece is gone. All hell will break loose. So if that's what you're worried about, it could happen. I mean, if they just immediately repealed some aspects, Medicaid expansion gone, all those people have no insurance like that. If they immediately repeal a lot of the subsidies and everything else, the private insurance market is going to collapse like that, and all hell will break loose. But they know all hell will break loose. I don't even think they have 50 senators to vote for that, like just repeal it right this second. So I don't think that's going to happen. Of course, I could be wrong, and time will tell. And we got to go. Let me make a few plugs quickly before we go, though. First of all, John has a new series, 100 Days. I'm actually, I believe, in one of the first episodes, or was it the first episode? One of the first episodes. You should go watch it and go watch the rest of it. It's quite amusing. My wife actually, I think, was in another upcoming episode when he's doing some exercise at a class that she goes to. It's great. You should watch it. I'm always funny thing that talks about how to change your lifestyle to make yourself better. It's worth it. I don't think we have a link at the moment, but you should go watch it. And then please, I'm going to actively consider, please go to NerdCon Nerdfighteria. It's in Boston. It's February 25th and 26th. We're going. I'll be brutally honest here, moment of truth. I'm panicked I'm going to be in an empty room. Like, I don't want to have, to watch John and Hank get a million people screaming and yelling in their things, and then we go to the healthcare triage room, and it's you and me and Stan and Mark in a room twiddling our thumbs. I don't want that. It will make me very sad. Please come. Please come. There'll be so many good things to see, so many good panels. I know I'm doing a panel with Hank and Emily, Emily Grassley and someone else in Holy Fucking Science. It's going to be great. I'm really looking forward to that. We're doing a couple other panels as well. I'm talking on a panel about how to, when YouTube isn't your first job, like it isn't mine. There's so much interesting stuff. Go! It's going to be great. It's going to be great. Plus, Hank and John and other famous people are going to be there, and I know they're the real draw. You should go. But come for them. Stay for the healthcare triage. But please do. So really look into doing that. February 25th, 26th, I'll be tweeting about it. I'll probably blog about it. You should really consider coming. And then we got to go. We're overtime. Patreon.com/healthcaretriage, hctmerch.com. Watch Friday's news episode. It'll depress you. It depressed us. Keep watching Healthcare Triage in general. The world's going to change on Friday. New president, new administration. Holy crap, it's going to be a fascinating time for healthcare. We'll be here to tell you what's going on. See you next week.